Good afternoon, everybody. Thank you all for coming. Today is the last session of our spring series of PEC Presents, our noontime seminar series in ethics. And very happy that you're able to come today. And we're very happy today to have Ellen Leahy joining us. My name is Mark Hansen. I'm the interim director of the Ethics Center. And just want to introduce Ellen. She's as many of you know, she's practiced public health in Missoula for more than 20 years. Is currently serving as the health officer for the Missoula City County Health Department, and she received her master's degree in nursing from Montana State University. I'm happy today that she will be speaking to us on the topic of public health and the public negotiating the intersection.
Thank you. Thank you for the invitation, and thank you for coming on what I've just learned is the last day of spring semester, which astonishes me. I'd also like to point out there's about 3 people in this room that could get together and give this talk, so it's extra nice for you to come, have friendly faces. I was asked to give the talk probably 4 or 5 months ago, and so it was interesting to see what the title was in preparing for it. Public health and the public. I really believe that, and I've come more to believe over my tenure in working as a public servant and a public official in public health, that the public has so much more to do with the public health than anything really that government or any other entity to do. It's truly a public venture. I came into it thinking it was more of a scientific venture, and while it has a lot of scientific aspects to it, it's truly a constant interplay between the public, the community, its values, its mores, its abilities, capabilities, and all the other players that are trying to promote the public health. In fact, I think the public and the health are so inextricably linked that they affect each other quite a bit. And I guess on the largest scale, a good example of that, if you look at Kofi Annan, setting up the Security Council to look at AIDS in Africa. That was really the first time for the UN to look at a plague like that as a security issue. And it was certainly more than compassion that was causing him to do that. It was because the public health in sub-Saharan Africa, because of the AIDS epidemic there, truly affects the overall security of the African nations. I mean, that's one way that it works. I think if you look at the opposite direction, we can look at the former USSR, where they had pretty good public health measures. Either that or they weren't really fully honest about those public health measures. But certainly when the government changed and there wasn't necessarily another government in place, let alone another public health system in place, the change of that government has affected, and all the pieces and parts, the economics and everything else, has affected the health of the public in a way that has never been seen in an industrialized country. That country is actually losing population because its birth rate is less than its death rate. So that is just a striking example of how the public affects the health and the health affects the public. In talking a little bit about the ethics of public health, I'm not an ethicist, I'm not a philosopher, but I do know the distinction between moral issues, which is, knowing the difference between right and wrong, and then having some standards that a profession needs to work toward in order to practice ethically. And what I really appreciate about the practical ethics group is that it's practical ethics and not egghead ethics. And so I think talking about public health and what it's really like out there in the community or in the world gives us a good sense of what affects the ability to be ethical. I also will talk in more of a common language fashion, again, because I'm not a philosopher and ethicist, about the public's ethic. And in a rather loose way, I need to say, and one of my main points is, the public has to have certain ethics about community, about tolerance, about ignorance and information and change in order for the public health practitioner's ethic to mean anything. And so what we're going to do is just visit a couple of vignettes over time and a couple issues going on now and a couple issues that we believe are coming up, just to look at that dynamic of how the ethics is always changing because the culture and the community is always changing, and to the great extent to which the public and their own culture and, in fact, ethics affects the public health and the outcomes. And some of these are real historical, and a lot of you have seen them, but there are so many lessons to be learned. Public health does have a code of ethics. It probably looks real similar to a lot of other professions' code of ethics, but there are inherent conflicts right in that code. Respect the rights of community residents. We certainly try to do that, but sometimes when we're imposing something on someone because they're affecting a larger group of community residents, they don't feel like their rights are being respected. In my first days, my very first day on the job in '83 was right after the air quality regulations, the Woodstock regulations went into effect, which is so long ago now. But I remember sitting there with an angry crowd of people calling us communists. And I was like, wow, this is not what I learned in school. To advocate for the disenfranchised, which is often people that are poor, but there are a lot of people who don't have a voice. Maybe it's because of the culture that they live in, or quite often in public health, it's the disease that they have. So it's difficult to advocate if the public doesn't want to listen. Address the fundamental causes of disease and the requirements for health. You know, that a lot of times comes down to poverty, and public health is not the sole agency charged with poverty. So sometimes our ethics in a practical way is, what can you do now to improve the health of folks while they're experiencing poverty? And that's a very different conundrum that we deal with. I think a good example of that is in our dental clinic. I'm looking at Karen Collins, who almost single-handedly, when she was the director of the Partnership Health Center, which is our low-income and uninsured clinic here in town associated with the health department, almost single-handedly, but certainly with some help, got us some dentists. We actually went from no dentists to dentists. But one of the ethical issues that we continue to face is we currently view being able to pull 5 teeth out of someone's completely inflamed, infected mouth, when they waited 6 months for that, rather than to do restorative care in their mouth. So in the practical ethics sense, that's progress. But it's certainly not the goal, and it's certainly not where we ultimately want to be. Improve the physical and social environment. I think we spend a lot of time, and people know about our attempts with others in the community to improve the environmental issues and the actual physical environment. But we get out with the social causes and are focusing more and more on social justice because of the equity issues that continue to affect public health. It's always hard to know where to draw the line there and when it becomes public health and when it becomes social work. Acting in a timely manner, we'll have some examples today where I would say timeliness was not achieved. And engage in actions that build the public trust. That's probably the hardest one, because sometimes the public will not trust you if you're trying to change the public's very values that they hold near and dear. So whether that's AIDS and needle exchange programs where we have been unsuccessful in changing that public value, or I would say taboo, to allow needle exchange programs in this state. They're currently illegal. We still have to try to do that, and that does cause sometimes the public to distrust while we're trying to do that. So inherent conflicts. Having said that, now we're just going to skim through the decades and see how some of these issues and how some of the things about the public, not just the ethical issues, but more so the issues of the public, its economics, its fear, its tolerance, what age of history it's going through. And you can't start a public health talk without talking about Mary Mallon, who's the lady on your left. And I call her Mary Mallon because her dying wish was to be called Mary Mallon and not be called Typhoid Mary. But there she is, and she was eventually, to make a long story short, locked up. She was locked up in that she was put on an island and she couldn't leave the island in the East River for, I don't know, Dr. Swift, 2 or 3 decades at the end of her life. And when you look at that whole issue of the public good and civil liberties, which we deal with quite a bit in public health, and you know that Mary Mallon, in fact, repeatedly went out and spread salmonella, and excuse me, typhoid, which is a salmonella typhoid, I'm sorry, but it's typhoid fever, to people, and in fact, many of those people died. You might think, well, you know, that's a really good case to lock her up. But it's a good example of how information was changing at the time, and the current ethic at the time could not deal with the real situation of Mary Mallon. And the real situation was she was one of the first people known to be a carrier of typhoid. So she was never sick. She was never sick. And the idea that you would lock someone up who's never sick, and that you'd lock her up for the rest of her life, finally you get to a point where maybe that's not practical. And when we look a little bit further, and this was a time in the late 1800s in New York City where the police powers of public health were grand. They were at their height because we were cleaning up the streets and trying to wipe out infectious diseases, and police powers were just, you know, at their grandest. We would never get away with that in a regular way today, short of a huge epidemic. Well, Mary Mallon, in addition, when you learn the rest of the story, there's something else about the public in the times that affected the ethics of what happened. And I'm not trying to go back and say they were right or wrong. I'm just saying this is the time that they lived and what they had to deal with. Today, we can give a carrier antibiotics. If they don't take their antibiotics, we can say, no, you cannot be a food handler, and then we could go to court if they could persist to do that. But back then, they couldn't. Was she the only carrier? No, no. But she was a female Irish immigrant carrier of typhoid. And so she got put away. There's even a picture of her, it's a drawing, where when the epidemiologist found her and said, you know, you have to quit. This was her livelihood. She was an Irish immigrant domestic. That's what the women from the famine did. They came over and did the domestic work and said, you know, you're sick. We're going to take you away. We're going to, you know, do some tests on you, and we're going to, you know, you're going to lose your job. There's a drawing of her with a fork attacking the epidemiologist, you know, just beating him with this fork. Well, if you step into her shoes, it made sense, didn't it? So she got put away for her rest of her life, and a lot of other carriers didn't. And I think a lot of it had to do with her inability to understand if she wasn't sick, how could she be spreading sickness? And of course, being an immigrant, it's easier to focus on the immigrant. New York City, most of this country's public health history comes out of New York City. One of the big things that public health deals with is fear. Whether that fear is warranted or unwarranted, sometimes it's collective fear. And this is a picture that a lot of people in this room know. This is one of my very favorite public health history pictures. And this was a cartoon from the time of like the 1865 cholera epidemic in New York City. And this is cholera itself. It says cholera on the belt, if you can see the belt. Riding into the harbor. And here we have the people with their arms upraised and their clubs. Because they've had cholera from Europe before and they don't want it again. And where does it come from again? It comes from the immigrants. It comes on the ship. You know, but it really spreads. Why? Does it really spread because the immigrants bring it in? It really spreads because the sanitation conditions for getting rid of sewage and keeping water clean were not up to speed in New York City at the time. And so you get this kind of false focus. If we can just focus on the immigrant, which is in part acceptable and practical, then we don't focus on how it spreads. There's a danger there. There's not just a moral and ethical danger. There's a danger that you haven't and aren't going to spread or stop the spread of disease. But what we really have going on here is fear. And this quote, "Fear seemed to absorb all the finer feelings of the heart," actually comes out of a story about the yellow fever epidemic. But a similar thing happened in New York City. When they knew cholera was coming again, because Europe would get it the year before, and it literally crossed the ocean, half of the people in New York City fled. Half. That's a lot of people. And they took cholera with them. So we talk about disasters bringing people together. Well, disasters that involve communicable disease have just as much tendency to drive half of them away and to be at least uncooperative, if not panicked. So What is the community ethic that we need there? This is another vignette, and again, it's a true story. This is a woman who has cholera. Washerwoman's hands is what was talked about as one of the main symptoms, and you can see how these hands look actually quite a bit older than her face, although she's sunken all over. Cholera, which we were just talking about in New York City, would kill within 24 hours, and it would do it with diarrhea and, of course, dehydration. So when you see something this ugly and this scary and you think you might have been exposed to it, and you probably were at that time, you ought to get scared. That's fine. But it's really interesting that at the same time we were dealing with this in New York, well, we weren't, but I read history books like a maniac, so we were dealing with this in New York City, and we were dealing with the fear of it, and it had just been dealt with rather unsuccessfully as well in London the year before, that fear ruled instead of science, because by this time in history, it was known how cholera spread. It was known. But the science doesn't always prevail. Sometimes the fear prevails. And the science was evolving, okay? And the science about epidemiology, even though it was already getting a foothold by a gentleman by the name of John Snow, and if you ever take a public health test, you have to know about John Snow, the epidemiologist, who understood by going door to door who got exposed to what and what the common exposures were, and therefore then he could say what the source was. He went around, and this is the same cholera epidemic that the next year came to New York in 1864. And he went around to where a lot of the cases were, and he interviewed. It's common practice today, 150 years later. He interviewed all the people that had cholera, and he marked them out. And he said, well, they don't all live near this Broad Street pump, but on their way to work or to market, they all drank from the Broad Street pump. And this was the beginnings of the epidemiological practice of mapping it out, looking for the common source. Historians rediscovered John Snow. We all think, oh, he was the beginning of it, but he did not prevail at the time. Just like some of the science that we now hear today, we think, oh, it's a little goofy, or we're not sure, or, he didn't prevail at the time. This was what the political body that was in charge of dealing with the epidemic in London in 1854 believed what was going on. They were pretty used to the miasma theory, which is you breathe bad vapors and there's different atmospheric conditions, and then the air is not salubrious. It's not healthy. It makes you sick. And so at the same time, John Snow was making his map, and they were looking at an officially accepted, and this is from the American Public Health Association's journal, where they do some look-backs in history, something that seemed to prove the miasma theory, because they looked at the big peak here are the cholera deaths, okay? And then you have a peak in the mean daily temperature of the Thames River, and you have some air pressures that tend to coincide with the peak. And it kind of all lined up really nicely, and the science looked really, really good. So we're always dealing with that in public health. If you don't know what the cause is, or if you think the cause is outside of your control, what is your ethical expectation? And I think we deal with that in cancer a lot. I think we know some risk factors. We certainly know some known carcinogens, but we also know that we have a breast cancer rate, for example, that is really quite high and continuing to get worse. And how are we supposed to prevent that? It's very difficult to go from known science, like germ theory, to science that isn't as well known, and that affects the ethics. So sometimes we in public health are accused of turning our head on cancer, simply because it's hard for us to go out and say what you should do or shouldn't do. One of the really interesting things in public health practice that I just delight in is the political aspect of it. And I don't always delight in it. If you've worked with me, I tend to go, I'm speaking of Irish women, I'm Irish, and I tend to go nuts when elected officials decide that the politics of the day are a little bit more important and decide to be a little more expedient with the politics of the day. You can go through newspapers all the way up to the current day, and you can find, and I like elected officials, and we have good ones here. We really do have good ones. But particularly in this country where the people elect, and that's who the leader is, good or bad, right or wrong, it is very difficult to have a supposed expert health authority come out and do something that doesn't look to the elected officials like it's good for the town. And closing down the town and letting the people know that cholera is running wild is economically not good for the town, not only during the epidemic, but for years afterwards. Toronto dealt with this recently. Now their elected officials and health authority did a really beautiful job. So you'll see this a lot. We prefer to take our chances with cholera than to be bullied into health. And he thereby, after that, was able to get London to repeal their Public Health Act. Okay? When New York City put their Metropolitan Public Health Act in, which was in 1865, right after this cholera epidemic, the year it came over, actually, to this continent, the mayor decided that he couldn't listen to the health board, and they ended up jailing him so that the health board could go about his duties. So in a free country, you not only have the issues of liberty and freedoms to deal with and imposing different restrictions on people, but the whole idea of the elected versus the expert kind of comes into play. This comes from the time where we were cleaning up because of cholera and because of other diseases and because of typhoid. And public health, and I'm guilty of this as much or more than anyone, public health really uses the bully pulpit. Because really when it comes down to it, there's only so much you can do with police power. People either cooperate or they don't. You can't lock them all up. You can't do that. And so as we learned more about sanitation, the mottos came out about how cleanliness is next to godliness. And this is where that phrase came from, was in the sanitary era in the mid to late 1800s. And here we have, our safety depends on official vigilance. And so that's our powerful health officers at the time. And here we have cholera, again, written here, and the angel of cleanliness. Well, you know, that's all fine and good, but there's a downside to that. And that's the people that maybe for a lot of reasons can't be clean, then all of a sudden aren't next to godliness, and they're bad. And if these are the very same people that you'd like to help be more sanitary, calling them bad and calling them other names is not particularly practical. It doesn't work. So here we're jumping now. We're going to stick to Montana a little bit more from here on out. To the health officer, Dr. J.W. Gunn in Butte, and all public health history in Montana comes from Butte. That's where it comes. You won't find any fun stuff in Missoula. It's there. And he was trying to get the poor miners in their slum areas to clean up. And I don't think this was a really good, effective way to do it. But then he did have a lot of police power. So that's the downside, is you start blaming when you have these nice mottos of cleanliness and self-responsibility. And, you know, we're working a lot on self-responsibility with smokers. Well, that can go too far. People that smoke aren't bad people. They're not immoral people. You know, they have some issues, and, you know, we need to try to, you know, maybe educate and convince and help. But that's always the downside of the bully puppet. So ethically, we have to be very careful about that. Another point here is that Dr. Gunn is once again talking about immigrants, because 25% of Butte's population, when he made this statement in 1893, now it's burgeoning. Butte is burgeoning at this point. It has all the public health problems of New York City, just a smaller scale. It's not a western town. It's an urbanized, industrialized, burgeoning town. So all the sanitation and epidemic issues are at play here. 25% of people in Butte were Irish immigrants, but 90% of the miners were immigrants. 90% of the miners, and that's who he's referring to. And you get this concept of other. You know, I would think it'd be hard for these guys to be clean, even in their homes. they worked in conditions that killed. If they didn't die from mining accidents, they died from infectious disease, quite often tuberculosis, but at the time it was called miners' con. They owned it, miners' consumption. And it was probably a mix of silicosis and TB. And how the doctors sorted it, I don't know, but they did. And it kind of, you get the idea, and you still get it today, that these industrial things and health problems, they just come with the territory, right? Because you got to make a living. That's an attitude we still have today, and we'll visit Libby later in this talk to take a look at how that attitude continues to prevail. Well, speaking of today, and I know I'm on camera and I'm saying this, but we just talked about blaming the other. And the idea that the other person's responsible and it's their fault. This is our current director of the State Health Department, Dr. Winia. This is a quote out of the Missoula, December 24th, 2004. He says, "Our biggest societal problems are of a moral, spiritual, and behavioral nature that government can't do anything about." And I have a lot of trouble with the moral, the word moral in there. Yes, there are a lot of behavioral, but in the context, it's blaming the other. And what happens when public health officials take this rather hopeless, and I would go so far as to say blaming view? It's an abdication of responsibility. Because if they're responsible for their problems, I don't have to do anything about it. They want to live in filth in Butte in 1893, not my problem. They want to have a moral problem with drug use or alcohol or whatever. It's not my problem, it's their problem. He didn't exactly say that. That's why I put his exact quote there. That is the message it sends. And this is ethically what we in public health must guard against. Because to do otherwise stigmatizes and abrogates our responsibility. I want to touch back a little bit now to Butte about how that feels, how that stigma, that feeling of hopelessness and something that you just can't talk about manifests itself. This is one of my very favorite quotes from Montana public health history. "Only one more clean shirt" was how people referred to someone who had miner's con and was about to die. And the only one more clean shirt was the clean shirt they're going to put on him to lay him out. That's stigma. That's hopelessness. And there are times for that, but at that time, there was still more that could have been done, that was known and available to be done. But the economics, the work ethic, the things that were going on got in the way, so that perfect ethic couldn't be reached. This is a Butte sanitary survey in about 1915, and following up on why do the poor people have more tuberculosis. And they went out and looked in the poor neighborhoods, and what did we find? We find more filth, we found more dirt, we found more poor living conditions. And that's important to do, and we find that today. And it has to be recognized. I am not suggesting we turn our heads. One of the biggest problems I have in working public health, even here in Missoula, doesn't have anything like this, is that we have places where sewage surfaces on the ground and children live in it, and our community doesn't know about it. And so it's important, it's an ethic, I believe, as part of advocating for the disenfranchised to talk about it. Unfortunately, it can get turned the other way. It can again be blaming folks. It's interesting that the industry of the time, their conditions were incidental and unavoidable. You work in a mine, you're going to die of something from the mine, very likely. TB, of course, was highest in the poor neighborhoods. It was very, very deadly in Butte. There were times in Butte when, according to Dave Emmons, who's a professor emeritus from this university and wrote the Butte Irish, that the TB rates there were twice what they were in New York City, Chicago, Philadelphia, and some other places. Very, very high. So it's unavoidable in the mines, but it's the problem of the people in their own living conditions. And it's not. It's a combination. And so trying to look for the fault or the blame and not being... And if that wasn't bad enough, here we have the Native American wing of what became the TB Sanitarium, Galen. Galen Sanitarium was set up, it was advocated for by a Butte gentleman. It was established in either 1911 or 1913, I get them mixed up. I think it was the 1911 legislature. Native Americans who had TB rates as high as folks in Butte, in fact their TB rate among their infants was very, very high, killed a lot of infants, were not allowed in Galen until they added this wing in 1954. So again, it's other. We tend to look at other. And one of the community ethics I think the public and all of us need is that, again, it's a community ethic, that it's all of us. And the good thing about communicable disease, its saving grace, is that it's spread. So it couldn't just stay amongst people that society could ignore. And that is how it often got our attention. So plagues and prejudice are locked. And I need to move, I'm talking too much. In Montana, another little story that was true that tells us a lot, not just about Montana, but about why, for example, it took 175 years from the time that the smallpox vaccination was developed by Edward Jenner and made available in this continent 3 years after he developed it, and I think it was in 1796, so by 1800. And that smallpox wasn't eradicated worldwide until 1976, so 175 years from the time we had the science, the medicine, the intervention to actually eradicate the disease. Why? Because public health is public health. It's different in every economy, every culture, and it also tends to only rear its head up when you get a big epidemic or when something happens that scares people. That's where public health policy and public health money starts to flow. And smallpox in Montana is a good example of that. A new form, a rather mild form, arrived on the continent in 1896. Nice seasonal epidemic waves here. Hits Great Falls, which was just really starting to build. The railroads were in. And it finally finds enough people to kind of take hold. But it didn't look like smallpox, and it's not always nice in a developing town to quarantine. It's hard on the economy, looks bad. So the physicians continued to call it chicken pox and refused to quarantine. Now, in fairness to them, it really was a different kind of smallpox. So here we are in Great Falls, 1899. It's just there right now, but they're arguing, is this smallpox or not? In the meantime, failing to quarantine, people are getting on the train, they're going to Minneapolis, it's exponentially multiplying. I didn't show you the real smallpox, it's so hideous, but the way you can tell this is minor, a variola minor form of smallpox, is this person standing. That would be one of the first things you would notice. What's really neat about this story, and it's another thing I want to introduce into how the public and public health deals, is that whole human concept of denial. Here we've got smallpox just streaming out of Great Falls. It's going everywhere. We've got guys in lumber camps. We've got people in railroad camps. We've got people, moving all over developing western Montana. And we've got Missoula saying they don't have smallpox. Now, I've been in the records of the time, and Missoula had smallpox. But it was expedient for the newspaper. And under their headline, under the masthead, Missoula, it talked about their goal was the development of the West. So it was very expedient to say we didn't have it. We didn't have it, but we did have it, and that's another story. So within a couple years, we had smallpox. By this time in 1902, it was just flaming up in Kalispell. There were only 16 counties then, so these numbers. We don't have 56 counties there. And of course, this was Missoula County at the time, and they didn't report because there's no smallpox there. So denial is a really, China did that with SARS, right? Vaccination, gotta go fast. Vaccination is probably considered one of the more invasive things that you can do to people in a free country. Now, we can't legally hold somebody down and vaccinate them, nor would we, but we can restrict them from certain gatherings, including important things like school. And this has been tested by the Supreme Court. It'll be tested again. I'm sure that it will. But here we're back in Butte, and again we have a different health officer talking about the ignorant and the irresponsible not wanting to submit to vaccination. And this was during the smallpox outbreaks. So the cases were really spread because vaccination only took place during outbreaks, so it wasn't in place to prevent outbreaks. And you know, that whole human nature of I don't think about fixing my roof except when it's raining, but then when it's not raining, you don't go fix your roof. That's a big part of the public. It's human nature. It's a big part of what we in public health do. We aren't always the ones beating the drum. We're sometimes responding to the public beating the drum. This is my favorite picture. Dr. Swick's familiar with this. But people were afraid of the smallpox vaccination. This was a new idea when it first came out around 1800. And they still politically didn't like it, particularly immigrants, because they'd been forced to get it in a different political setting. And this is a cartoon from London around the time it first came out. And because they knew that the pox material came from cows, you use cowpox to create the immunity, these are people getting it, and if you can get up close, you can see that they're developing all sorts of bovine features. We have cows sprouting out of noses and cows coming out everywhere. So they were, truly, it's funny, but they were truly afraid. You can take this pussy stuff and you put it under my skin, and this is my duty. So we have to be a little understanding, I think, of where some of this comes from. Finally, we got a state health board because of this outbreak that raged for 5 years. This is the petition for the state health board, but the majority of signatures, hundreds and hundreds and hundreds of signatures on petitions, were against the state health board because they considered it class legislation. Why? Because when you impose quarantine on people, you're really affecting the poor. They're going to lose their job if they're quarantined for 3 weeks. The wealthy could have a nurse come into their home. But the poor had to go to the pest house, the pestilence house. And this is the pest house in Butte in 1915. And you're in the pest house. And you're there whether it's a good pest house or a bad pest house, whether you're going to catch what the other person has or not. In fact, smallpox was so contagious and scary, they used to either put tents up or build little claptrap kind of pest house so they could burn them down when it was over. This just shows you poverty and health are linked. I need to move. I put this in because it's my favorite, my very favorite one about how culture and what taboo is at the time and how it affects what you're allowed to do with public health. But during World War I and World War II, this is in New York City, it was perfectly acceptable to put up public ads about gonorrhea and killing it. One of the reasons it became more acceptable wasn't just because of wartime, but it was because we now had something we could do about it. And we tend to, do something when we can. Just want to visit Libby, Montana, lest we think that these challenges have been met. Libby, Montana, as many of you know, has what I believe, let's hope it's the worst environmental public health disaster this nation ever sees. Let's hope that it is. But it really hasn't begun to unfold. We've got a latency period for disease to develop from exposure to tremolite asbestos that's as long as 40 years. And if we looked back, if we could look back, I don't think we'd ever find how many people were dead from it. People did know about it. People in the town knew. It was, came with the territory. You worked in the mine. Some people, though, I think, and this goes below ethics, I think there's serious moral problems because some people, including public health officials, didn't do anything about it, and others actually lied about it and covered it up. So, lest we think that it's Libby's problem, that it's the others, that we don't have to worry about it, this is the EPA map of where Libby exported to different mills that very material. It's all over the country. It's in homes as insulation in the country. And it's an interesting ethical question for the EPA. about how far they are and aren't going to go to at least inform about this. It may not be practical to abate, but is it ethical to at least inform? This is cutaneous anthrax. I want to tell you that in my over 20 years of experience in public health, I never got so much money coming to a local health department, ever, by order of magnitude, than I did after we had the anthrax scare. Hundreds of thousands of dollars a year. And it's not what people are dying of, and we're making good use of the money. Earl, former assistant fire chief, came over and taught us all sorts of things. We were had a little hard time thinking like emergency workers, but he taught us. But we're using it to build the public health system so that we can deal with things that might happen. I've got to skip SARS for a minute just to show you. One of the other things that really affects the public and the public health is perception of risk. And I don't know if you remember how scared everybody was of SARS, not so much in Montana as we were in bigger cities, but we were busy with SARS. And I just love this New Yorker cover because they've all got their masks on when they're out having their smoke break. And the perception of risk, is completely topsy-turvy. These people weren't going to get SARS and they weren't going to die of it. It's got like a 3% fatality rate, the same as normal flu. Scary, yes. Something to be dealt with, yes. But nothing in this country, nothing, you can add them all up, kills like tobacco. Nothing. It's still number one. It's accountable for 1/5 of all the deaths in the nation. So perception of risk does drive public health, and that's sometimes difficult. In China, when they finally got caught, they fumigated the streets because they needed to look like they were doing something. And of course, it had nothing to do with the airborne spread of SARS. And then on the other, continent, we've got perinatal HIV, and this is a woman giving birth, and she has a 30% chance of spreading HIV to that infant that's being born right now, if the infant doesn't already have it, either through breastfeeding or through birth. And where's the outrage we had for China for covering up SARS? I mean, the life expectancy in Africa is just plummeting because of AIDS. And one of the really interesting ethical dilemmas, I think it's an issue between ethics and morals, if you understand the distinction, and I think I barely do, because I'm not an ethicist or philosopher. But the people that work over there, Doctors Without Borders, for example, is responsible for having a midwife there for this lady to deliver with. They want to give the drugs to the women that are still somewhat experimental, but we believe would stop the spread. The researchers have a different ethical standard. And their ethical standard says you can't give a lesser drug to a population if you know you've got a better one. And this goes on in the literature, so there's some real ethical dilemmas. The last thing I want to say is how we're looking at the ethics as it relates to, and I've got 2 minutes, so if you have to charge out, fine, I'm going to flip through these. How to use ethics and all we know about public health and culture to look forward so we can think about our ethics ahead of time. And we fully expect, I don't know when, and I don't know how bad it will be, but there's no reason to think that there won't be a flu pandemic. There's all sorts of evidence that a flu pandemic, similar to the 1918 flu, and if you want to visit a little Montana history, when you leave the building, where is that? Where you walk, before you walk to the Adams Center and you're going past the tennis courts, there's 2 rows of trees in memory of people that died from this university in the 1918 flu epidemic. It killed more people in a shorter period of time than ever in the world as far as we know in terms of world history. Certainly more than died in all the years of the war that was going on at the same time. These are saddle police wearing there. So we think it's coming. It was so huge that this is what it did to life expectancy in this nation, which was growing. It's 1918 flu. It's huge statistically for that to happen. Now, when you see this scene, we see a nice community ethic of people in this community, hundreds, over 1,000 people in this community that cooperated and showed up for our flu clinic as we asked them to, that self-screened. And if the community, that gave up their shot so someone else can have it, and that's the community ethic that has to come into play. But what this also tells me is we're not ready for a flu pandemic. It may be that there's no vaccine, that's quite likely. But it may be that there's antivirals. Will there be enough? Are we ready? So what we try to look at for quarantine is there's 3 ethical tests for quarantine put forward by a group from Johns Hopkins and CDC, all come together and published in the Journal of the American Medical Association. Those 3 tests are, in that situation, is quarantine in fact warranted by public health and medical analyses? Not because people are afraid. People were afraid of AIDS and they wanted to quarantine people with AIDS. It's not warranted. Okay. Is it feasible? How many people would you really be quarantining? Could you identify them fast enough, and could you put them somewhere? And 3, do the potential benefits outweigh the adverse consequences? So quick pictures and I'm done. You have to look at the agent, the immunity of people, and the degree of risk. Now, head lice is something that drives people in schools crazy, and my phones ring off the hook, but we don't quarantine for head lice. Okay? Degree of risk. Annoying, ugly, don't want it. No degree of risk. Is it feasible? These are flu tents from the 1918 flu. Well, it might be feasible to put people in tents, but I have to tell you, between then and now, we have some civil liberty issues that have really come into play with all the civil liberty and Supreme Court cases that we've had. And those include the ability to care for people. If you're going to put them somewhere, it can't just be a pest house. And are people going to cooperate? Police power will not work in large scale. It has to be cooperation. And will it work economically? The last thing I want to leave you with, I leave every lecture with, and this is my motto, my view of what public health is. And I think it points out why public health folks need to have an ethic, but so does the public, so does the community. And it comes from Bring Out Your Dead, which is a story of the true story of the
1793 Philadelphia yellow fever.
Yes, 1793 Philadelphia yellow fever. Doesn't matter if it's tobacco, if it's violence, if it's meth, if it's SARS, if it's flu. It all matters how we deal with it. And I really thank you for coming today on this last day of the semester and listening past the hour. Thanks.